everyone. I think it's
Hi, Dr. Purvi.
Hi, Ratna. How are you?
Good. How are you feeling? You are not well now?
Yeah, better. I think it's rested it out today.
Good.
Hello, good evening.
Hey,
Good
Dr.
evening,
Madhavi.
Ratna madam.
Hello, Madhvi.
Hi, Purvi ma'am. Hi.
Dr. Jitendra sir is also joined. Mohite sir is also there. Good evening, sir. Hi, Amit.
Good evening, all.
Good evening, sir.
Good evening, everyone. Good
Good
evening.
evening, sir.
Madhvi ma'am, all set? Should we start?
Yes,
Yeah. I think. Dr. Vikram, is the YouTube relay started?
I think it's on
Yeah. Okay.
because there was a message saying so.
Yeah. Good evening, everyone. On behalf of IIP Navi Mumbai, I welcome you all to this CME on webinar on anemia. 13th Feb is also as World Anemia Day celebration. Though all of us are well aware but still there are many small loopholes or small mistakes or small gaps which still remains a major cause of nutritional deficiencies, cognitive malfunctions or cognitive disturbances in children. So here today we have two experts with us, Dr. Ratna Sharma ma'am and Dr. Purvi, and an expert from IIP Navi Mumbai itself, Dr. Madhvi ma'am, who will be moderating today's session. Is an EB member, not IIP Mumbai, but she is an EB member of Maharashtra IIP also, and she has taken up a role often being the editor, the co-editor for the Maha IIP. She's working with PGIMS and she is a very hard worker. She's worked a lot of oncology. So we thought she'll be the apt person to this session. So she's an associate professor with PGIMS. Over to you, ma'am. Please do the session.
a very good evening to all. Without much coming into our clinical discussion as well as the academic feast which we are going to get from our experts, I first introduce our respected speaker, Dr. Ratna Sharma ma'am, who is a director at CTC PHO BMT Center. It is a Borivali-based comprehensive care center for thalassemia. Madam is also a hematology consultant at Jupiter Hospital, Thane.
I think Madhvi has some connection network issues.
Yeah.
I'm getting freezed.
Yeah, you were frozen. Now you're there with me. Please continue, ma'am. You can switch off your video. That should help with the relay.
Is it okay now?
Yeah. Yeah. You can switch off
Better?
your video.
I'll switch it off, I think.
Yeah, switch it off. It will improve the relay.
Fine. So basically, madam, I have been lucky enough, fortunate enough to have a clinical acumen from madam during the residency. She has been providing an excellent public-private partnership teamwork since the past 25 years. She has many case reports, studies, review articles, chapters in textbooks on her name. And as we already know, we have been telling that madam is an important person in managing bone marrow transplant patients at a public sector. Without wasting much of time, I invite Ratna ma'am to take over the session.
Thank you, Madhvi. Thanks for the kind introduction. It's a pleasure here to be invited by Navi Mumbai, Pediatric Association, and to be a part of this session with Dr. Purvi and Dr. Madhvi. Thanks to everyone. And I'll just share my PPT so that I have something to talk more sensibly. So is my PPT visible?
No, ma'am.
Not yet?
No, not yet.
Just a minute.
Yes, ma'am.
It's visible? Yeah. So
Yes.
I will minimize all of you so that I can only see my PPT. Yeah. So this was the topic I discussed with Dr. Mangai, and we said we'd speak on this, what the pallor of strategies for childhood anemia. And as I begin, I've been treating from my center, which is the CTC PHO BMT Center at Borivali. Some of you have visited the center, others who have not, you are most welcome to come and see the work that is happening and join hands with us in trying to make more meaningful changes in the field of hematology and oncology. So World Anemia Day, as Dr. Mangai just mentioned, is observed on 13th of Feb. It's World Anemia Awareness Day. And we were supposed to have this session probably last week, but because of coordination, we are having it this week, which is not far from 13th of Feb. We are trying to make meaningful discussions over here, me and Purvi together, as to how we can actually connect, as pediatricians and hematologists to see whether we can make some difference into the prevalence of anemia in our country. As we all know, anemia is a serious global public health problem, and 42% of children all over the globe and 40% of pregnant women are anemic. And we have heard this for years since our student days, but the numbers don't seem to be changing significantly. The magnitude of the problem, if you look at the world population today, 8.1 to 8.2 billion, out of which 2.4 billion are proven to be anemic. 1 to 2 billion are iron deficient. So the number is huge. The global prevalence is 41.4% in children below 6 years of age. And iron deficiency still contributes to be the most important cause of nutritional deficiency in these children. It's the pregnant women, the children who are less than 3 years, either in the rural or urban area. The prevalence is significantly high, as you can see from this slide. So I'll use the pointer here. So 72% in urban and 81% in rural. So it doesn't change as the families move to the urban areas with better hospital facilities, better access to health system. The problem still continues. So it is one of the biggest health issue right now. Awareness is very low. The awareness that we feel within medicos in the city probably is high, but the awareness is currently very low when you look at the globe at large or also our country in general. World Anemia Awareness Day is observed on 13th of Feb, as the number 13 represents the ideal hemoglobin, which is optimum for anyone's good blood health. So that was the reason they chose 13th as the date in the month of Feb. The idea was to connect experts, communities, and individuals in the call for stronger blood health for all. This term, stronger blood health for all, I think should be picked up by everyone. And the desire should be that as we talk of good health in general, we should be talking of stronger blood health henceforth. As Indians, we should be logging onto this website by the National Health Mission, which is Poshan Abhiyan. This is visited only by 4,35,000 visitors so far. It has a dashboard where it talks about the Anemia Mukt Bharat program, which was launched way back in 2018. And we need to see what all has been done and what needs to be done and how far we have reached in trying to make our country actually anemia free. So this dashboard actually talks of where India stands. And if you see, India has, with dark blue, that means more than 40% of our population is anemic. Compared to the rest of the world, our prevalence is much high, 53%, almost similar to our neighboring countries and some countries in the African subcontinent. India, if you look at 53%, Maharashtra stands even higher than the rest of the country, 57.2% in Maharashtra. And if we actually zoom down to the Mumbai suburbs, the Raigad district and the Thane, I assume that the audience or those who have logged in for this session belong to one of the three. The prevalence is very high. If you look at Mumbai suburban, it is 67.2%. So what is going wrong? Thane has 58.5 and Raigad is 61.1. This is all from the data that is there on this dashboard. So as we understand, anemia can be a silent presentation. It can be silent. A person may live with anemia all his or her life and may not even do anything about it and carry on with routine activities with maybe compromised functions. It could be just a lab finding to you in the office with or without cytopenias when patient walks in with a report for whatever reason he has done CBC. Anemia could be the presenting, it could present as classical symptom. Patient may come with, anemia with signs of failure or signs of fatigue, lethargy in your office. And that would be a classical presentation of anemia of any underlying cause. It could be a supportive evidence to reach a diagnosis sometimes. It could be a presenting feature of many diseases. It could be a complication of a disease secondary to blood loss or any other complication where iron absorption is poor or the kidney is not functioning. So anemia can have varied presentation, varied causes, and it could even be a complication. The simple approach that I've always tried to, understand for myself as well as when I teach is you have to remember anemia is caused either by blood loss. It is caused either by reduced production of RBCs or faulty production of RBCs, or it is caused by destruction of RBCs. So this is the common three divisions in which we say that anemia causes have to be divided into either of these three. Decreased production could be marrow failures, marrow infiltration. Faulty production could be ineffective erythropoiesis or dyserythropoiesis. And destruction, as we know, could be immune or non-immune causes, where in non-immune you have enzymes or membrane as most of the common causes. So if we take a detailed history, examine a child thoroughly, and classify through history and examination, make our classification as to what could be the probable cause of anemia, most of the time we have a diagnosis even before we have investigated a patient. The minimum investigation that would add to your clinical diagnosis would be a CBC and a good peripheral smear. CBC with the current indices that are available will give you most of the answers, and the remaining test you might just do to confirm your diagnosis and to establish the true cause and be confident about treating the cause of anemia. So in medical history, patient characteristics, the age, the gender, and the ancestry matters. When I say age and gender, obviously infants and toddlers coming with anemia very early in life, you have to look for inherited causes. If they're coming with liver and spleen, hemolytic facies, it could be thalassemia. If it is a male child coming with jaundice, you should suspect G6PD deficiency if their presentation is acute. If they come from certain communities where thalassemia is prevalent, then again you are, with consanguineous marriage, you have to suspect thalassemia. Certain communities like Punjabis and Sindhis have G6PD deficiency more common. So a history in general helps you to understand what could be the probable cause. The presenting symptoms like pallor, jaundice, if the patient has come with jaundice, obviously you could be dealing with indirect jaundice, and you know the cause could be hemolysis. The patient presents with blood in stools, you know there could be blood loss, excessive menstrual bleeding could be contributing to anemia, which with an underlying iron deficiency anemia, if it is long-standing. So all these things have to be looked into when you're taking a history based on the age, gender, and what the patient has come with. You also need to ask whether the parents have noticed acute onset of anemia or pallor, or this has been gradually dipping and the child has been lethargic, has been experiencing fatigue for some time, and now he's come with a very low hemoglobin or significant pallor. Has he received transfusions in the past, and whether this is a recurrent problem? Whether there is history of any infection or underlying chronic disorder for which the child is undergoing treatment. Is he on any medications? Is he exposed to any toxins which can cause, for example, exposure to lead, which can cause anemia? So a history becomes important. This is a cartoon depicting the sites where you need to check for anemia. So palpable conjunctiva, tongue, buccal mucosa, palm and nail bed. I'm sure all those who are listening to this talk obviously know how they have been assessing pallor in their office clinics. So the clinical findings that you need to look for along with pallor is whether the child has hyperpigmentation, specific distribution, classical or B12 deficiency, perioral distribution, which could be classical of anemia with short stature and other facial features like microcornea, microcephaly, a sallow complexion which could be in favor of B12 deficiency, hemolytic facies which could be in favor of hemolytic anemias like thalassemia, glossitis, angulostomatitis which will give you clues towards nutritional deficiencies, platinacea we've all seen in our clinics, triphalangeal thumbs, hypoplastic thinner eminence, all in favor of inherited causes like Fanconi anemia. If you're looking at pallor and it is with organomegaly, obviously another Pandora's box opens with differential diagnosis where there is anemia with hepatosplenomegaly. And if there is lymphadenopathy also, and if the child is sick, you will also think of pancytopenias where anemia is the first presentation or the parents have picked up anemia. If the child looks stunted and has pallor, obviously you will think of chronic kidney diseases, celiac diseases, and other chronic illnesses where anemia is just an associated finding. So after history examination, obviously the first investigation that is done is CBC. And I would request everyone who's listening here that if you're investigating or doing a CBC for pallor, always add retic count to your investigation. With hemoglobin, the CBC gives you various RBC indices, which will help you to conclude whether you're dealing with microcytic or macrocytic anemia, whether the RDW is wide or normal. As you all know, a wide RDW would mean that we are probably dealing with iron deficiency or RBCs of varying sizes. So if it is associated with microcytic anemia, you know that you're dealing with iron deficiency anemia. The new parameters, obviously the newer machines have newer parameters which are helping us to understand all types of cytopenias, and certain parameters like the hemoglobin content of reticulocyte does help in monitoring these patients, their response, and to differentiate whether it's availability of iron that is a problem or utilization of iron that is a problem in these patients. So coming back to the cause why we are having this session today, close to the World Anemia Awareness Day, me and Dr. Purvi will try to stick to more of nutritional anemia and more so iron deficiency anemia. So why are we discussing this year after year and decades on and on? So we know that we have looked at the approach to anemia, most of the causes other than nutritional, finally we end up diagnosing and treating. But what is the problem with nutritional anemia that we have not been able to take care of the high prevalence in our country? Have we failed somewhere? The Iron Plus initiative launched in 2013 and the Anemia Mukt Bharat launched in 2018. The efforts have been made, but we are not seeing the results as we expected. What are the challenges? Can we as a team make a difference? Are we doing our bit? And do we think that we don't have enough information or we don't know how to go about it? Do we need reinforcement, reminders, and are we adequately determined to do something about it? Is there anything different that we can do? Are we going to only blame the compliance of patients or is there something more to it? This is what I want all of you all to think, even as we are done with this session, and know whether you can contribute in some way to bring down the prevalence of nutritional anemia in our country. So what I would like to tell you is the office strategies that all of you can implement to contribute to this cause. First is prevention. Second is strategies in screening and early detection. And the third thing is treatment, basically, and that using effective formulations. Dr. Purvi will talk about it, the correct dose strategy, and adequate duration of treatment. And obviously, if it is not going to get corrected, look at the underlying cause, or if there are clues to the underlying cause to begin with, then actually proceed with investigation in that direction and pick up the underlying cause so that the child or the patient can be adequately treated and correctly treated. So let's talk about prevention first. The strategy that is recommended is delayed cord clamping. Every pediatrician should encourage exclusive breastfeeding for 6 months, and I'm sure all of you are doing that. Ensure proper complementary feeding after 6 months with adequate iron content in the complementary feeding that requires nutritional counseling. In case of preterm and low birth weight, supplement with 2 to 4 milligrams per kg of iron in the early infancy, right till 1 year of age. Implement regular deworming, which I believe most of you are actually advising your patients. And the last thing and the most important thing, where we feel that we have significant role to play, but we've not been able to implement it in our practice or emphasize it to the patients and the families who are visiting us, is the role of iron folic acid prophylaxis. Now, there are guidelines for iron folic acid prophylaxis through the Anemia Mukt Bharat program. There are age-appropriate doses for infants, for preschool children, for school-going children, and for adolescents. Bi-weekly to begin with, and then gradually moving to weekly. And this pattern has to be followed and given to everyone, irrespective of whether they have low hemoglobin or not. Those who have low hemoglobin need to be treated and then put on prophylaxis program. And those who have normal hemoglobin also need to go on this prophylaxis program. So this is the doses, and I'm sure Dr. Purvi will also repeat this in her presentation. This is available readily, and I think everyone should put up a chart in their clinic and follow this. If you put these charts in your waiting area, and if patients and their family read it, they will become part of this program, and it will be a part of a regular, supplementation program, which they will follow at home, advocate to other families also. So, and you can actually give them a handout of this if required. So that's about prevention. Coming to screening and early detection. So there are recommendations, but difficult to implement, about checking for hemoglobin at 9 months and school entry. But what we advocated, at least do the clinical examination and look for pallor at 9 months. If 9 months is missed, for 12 months, because these babies are going to come to you for vaccinations regularly. If they look pale, please get their CBC done. If the parents are willing, do a CBC. If not, start them on iron supplements. Second is the point of entry into school, and we have seen a lot of schools now making it mandatory for children to undergo a CBC before school admission. And this is the time when school admissions are happening for June. So there are so many referrals in the patients or in children within the age group of 3 to 5 years with hemoglobin in the range of 6 and 8. It is unbelievable. So rightly done at school entry, at least it's a good time to pick up so that the child, before proceeding for academic learning, actually has his HB documented and iron started. These are mostly kids who are not into the Iron Plus initiative or the program, prophylaxis program, and they need to be first treated and then put on prophylaxis. So in a way, it's good that the schools have this program, and it would be a good thing even if the school is not doing as a pediatrician, you could insist that the family does the check for their child at school entry for hemoglobin. Those who are following up with kids who are premature, low birth weight, they also need to keep a close watch for anemia in these babies and ensure that they're getting their iron prophylaxis. Kids, as we know, all of them don't have a good diet. Some of them with chronic illnesses or recurrent infections, all these are prone to iron deficiency. Adolescent girls with or without excessive menstrual loss are known to have significantly high prevalence of anemia, and these are in the transitioning phase from pediatrician to adult physicians, but they continue to come to pediatricians at least till the age of 18 is what we have noticed. And pediatricians would be the best people to actually ensure that they take their iron supplements as prophylaxis if they are not anemic, and to treat the anemia by therapeutic doses if it is detected. This, as a point of care of hemoglobin testing in the clinic, will probably become a norm gradually. We have so many things in our clinic now, including pulse ox and other things. Hemoglobin testing in the clinic, if available and if it can be implemented, and if the families take it positively that we are checking their hemoglobin, we might be able to pick up many more patients who are actually requiring therapeutic iron and therefore prevent further deterioration in their iron status before they actually land up with very low hemoglobin. So this might be something that few pediatricians might be able to implement. The machines are available. Accuracy is still being questioned, but for mass programs, it is being used. So what I would insist is that iron prophylaxis, iron folic acid prophylaxis, and screening for thalassemia to be something that all pediatricians consider as part of their role in the society as medicos, and ensure that not only the child but also the family, everyone is screened for anemia and for thalassemia. Why do I say so? Because there is not only decreased storage, the signs and symptoms are not there with decreased storage, but gradually it will lead to latent iron deficiency, ferritin and the transferrin saturation will drop. And by the time hemoglobin drops, a lot of damage is already done. It's actually overt iron deficiency by the time you actually see low hemoglobin. Therefore, there is a significant role of giving prophylaxis to everyone, irrespective of their hemoglobin value. This, for example, a 22-month-old boy was brought by his grandfather, an active toddler. Parents were thinking why the grandfather is, so much keen on getting the child to the pediatric hematologist. He got directly to the pediatric hematologist, and he was a picky eater. The grandfather was visiting after about 9 months. He found the child to be pale. The child loved milk and was drinking 4 bottles of milk. Both the parents were working from home. The child was comfortable with 4 bottles of milk. The parents were happy about it. So this is a classical history that we see nowadays, no significant family history. The child was otherwise well grown, weight of 13.2. He did have pallor. He looked very active in the clinic. He had dental caries, nothing systemically. His hemoglobin was 6.2. Probably by the time he would have entered school, he would have been 5, I believe. So he was 6.2. Thankfully, he was, got by his grandfather. He was classical iron deficient anemia. He had a little thrombocytosis. RDW was 19, which was wide. MCV was low. Smear showed microcytosis, hypochromasia, and mild anisocytosis. Iron supplements were started in therapeutic doses. I should say iron was started and milk intake was reduced and the child was much better. So this is a common history. Now in standard assessment protocols in office, what you could do. If you see a baby with fatigue, irritability, breath holding spells, pica, these are the ones who definitely would have iron deficiency. Febrile convulsions, or there would be high prevalence of iron deficiency, I should say, in all these. Those coming with declining academic performance, excessive hair fall, hypopigmented hair, signs that we commonly know and all of you pick up: pallor, tachycardia, glossitis, platinacea, I mentioned, hyperpigmented knuckles and growth issues. These are giveaway signs of nutritional anemia. So these are the ones where you should definitely do a CBC. And if you're doing a CBC for any of this presentation, but you overlook hemoglobin while investigating these children, it would not be appropriate. So in office practice, sometimes the focus is on chief complaints other than pallor, and you may miss treating a child for anemia. Child may be brought by parents with history of pallor, which could be acute or chronic, and that would be a time where the anemia has been long-standing probably or acutely presenting, but definitely it's because the parents picked up pallor, therefore they have come to you. Secondly, it could be that there has been some illness, CBC was done for that, and hemoglobin was found to be low. You could also have kids who are basically undergoing a CBC for pre-op workup, and you find that the hemoglobin is not normal. Now, what is not normal is important, because if the hemoglobin is above 8 and he's fit for surgery, he may go for surgery, but never come back to you for a low hemoglobin which needs to be treated. But it was, it was not brought to the notice of parents at that time. CBC could be done for school admissions, as I mentioned. CBC may be done by enthusiastic parents who are into annual checkups. And CBC may be done in adolescent girls or boys at health checkup because they are into various food habits or because of their lifestyle where parents think that they may not be fit. So you may be able to pick up all these patients, look into their CBC, dive into their indices, and understand that they all probably need treatment for anemia. So the recommendation is that if you see a less than 6-year-old with a hemoglobin less than 11, he requires treatment. If you see anyone between 5 and 11-year-old with hemoglobin less than 11.5, he requires treatment. And any girl about the age of 15, if she is less than 12, she requires treatment. So refer to these charts, which are WHO standard charts, and don't accept anything less than 11 as normal hemoglobin in a child, and less than 12 in anyone who's more than 12 years of age. So please remember that you have to treat anyone who's even 8, 9, 10, 11, and they are coming to your OPD. They require iron supplementation, and the remaining require iron prophylaxis. So in 2022, October issue of Indian Pediatrics, there was a joint committee set up by Dr. Jagdish Chandra as the lead. We worked hard during COVID time, around 18 months, to come up with these recommendations on diagnosis, treatment, and prevention of nutrition anemia in children in India, first of its kind. 4 of us, Dr. Manglani, Dr. Nitin Shah, and Dr. Pranoti, were all part of it from Mumbai. And we realized that this has become a reference guideline for many people in the Asian subcontinent. So the recommendations, I will just run through it in short so that these are useful in day-to-day office practice. In most clinical situations, a presumptive diagnosis of IDA can be made just on the basis of RBC indices and blood picture, and you could start the patient on ions. The classical triad of low MCV, low MCH, and low MCHC is enough to establish the diagnosis, and you need to start iron and document a response to iron. The CBC has a lot of parameters, but just stick to those which are relevant for anemia. CBC in the form of CBC would be giving you indices. You have to ask for a retic count separately from the lab and use it to know whether there is lack of production or more destruction to know the cause of anemia. CBC is no longer just counts, it's cellular intelligence. That is what I tell my students. It's a diagnostic and monitoring tool. It conveys real-time figures with amazing precision, and there is a lot of useful data being collected, which can be collated to understand these parameters, to understand the response to treatment also, and in making diagnosis also. CBC parameters don't look only at the hemoglobin, look at the RBC count, look at all the indices, specifically look at RDW in microcytic anemia. And if the RDW CV is very high, you know that you are dealing with IDA. If it is low, you have to screen for thalassemia minor. So the cutoffs through these recommendations, the cutoffs were given as to what is going to be called as microcytosis, what will be called as macrocytosis. The cutoff after you have done the CBC, and if you still want to confirm that this is iron deficiency anemia, the only investigation that needs to be done is serum ferritin and nothing else. Serum ferritin cutoffs are clearly defined, less than 5 years. Anything less than 12 is suggestive of IDA. In more than 5 years, anything less than 15 is suggestive of IDA. In the setting of infection, ideally don't do it, but if it is done, anything less than 30 is suggestive of IDA. So you should know how to understand it as microcytic. You should know that if you're doing ferritin, what are the cutoffs? And if the ferritin is equivocal and you cannot make sense of it, then do a transferrin saturation. If it is less than 6%, it is ideal. So these are the guidelines that are given, the recommendations to be followed. So the first test is serum ferritin. Serum iron, it's going to be variable. It is influenced by recent intake. So don't do serum iron. As I mentioned, the cutoffs for ferritin are clearly defined, and transferrin saturation should be your next investigation, which is a ratio of serum iron and TIBC. RET-HE can be done as a monitor to know the response to iron supplements or to differentiate whether there is decreased iron utilization. So RET-HB, it helps to determine the availability of iron to form hemoglobin. The new CBC reports, the extended reticulocyte parameters can be asked for if you're really wanting to assess the response. And you look at the retic count, which has gone up, and you look at the RET-HE, which is normal. That means the hemoglobin is entering the reticulocyte adequately. This is done to assess the response. It's not mandatory, but if it is done with RET-HE, it is more useful. So treatment, Dr. Purvi will be talking about what is the dose, the formulation, and how you restore and replenish the stores also. Dietary modifications need to be done. You have to ensure compliance. And if everything is not on track, look for secondary causes. Front, if it is not looking like classical IDA, or if there is not an adequate response. So non-responders, at the end of 2 weeks, in moderate to severe, you need to assess there has to be a rise in hemoglobin of 1 gram. In milder anemia, at the end of 4 weeks, the rise should be more than 1 gram. Okay, and all this will be reinforced again by Dr. Purvi, so I'll just move ahead. You need to evaluate the non-responders, look for whether you are dealing with some other condition which is hindering with iron absorption, like celiac disease, or you have not looked at dimorphic picture, B12 and folic acid deficiency, or there is some occurrent blood loss. Beta thaltrate, you should have ruled out at the very beginning. And IRIDA, if there is no response, you need to work up the patient for IRIDA. So, National Health Mission talks of 3 T's, that is test, treat, and talk about anemia in all the camps. I would say this can be implemented. These posters can be put up in your clinics where you make the patients talk about anemia to you so that you can tell them what can be done to prevent anemia. How far have we come in actually improving the current status in our country, whether we have brought down the prevalence? We have been able to cover with iron folate supplementation right from 2018 to 2023. If you see from 8% coverage, we have been able to cover 32%, and we have a long way to go for children less than 6 years, and similarly for older children, 40 and 46%. A long way to go to ensure that everyone gets it. If we talk that the impact on health is significant in child's behavior, development, learning disability, physical or work performance, and including immunity and the uptake of vaccine that has been documented, I'm sure parents will listen to us and continue with iron prophylaxis, and the compliance will be better. So this was a table prepared for Mumbai IAP, and they asked me to give one table regarding everything about anemia in children. It was difficult, but maybe this would be helpful to those who are, who want to just put it up as a chart where it talks about what are the normal hemoglobin, what are the causes, what symptoms you should be on a lookout for with signs, and how to interpret the RBC indices to come to a conclusion as to what could be the cause of anemia. This is in short. I'm sure we all have looked at flowcharts during our, MBBS and MD days, and we follow those flowcharts. But this is just a summary. Good peripheral smear examination, especially for hematologists. The role of retic count in understanding destruction versus reduced production. Other tests to establish what you have already suspected with what is done already above. That means history, examination, and indices. Treatment in short for iron deficiency anemia, B12 and folic acid with supplementation. Hemolytic anemia as packed cell transfusion and supporting with immunosuppression till the whole thing clears. In immune hemolytic anemia, bone marrow failure, earlier we would only give blood components, but now we have an option of doing transplants in them, and the scenario has totally changed. Anemia of chronic disease, we have more specialists taking care of chronic diseases. The children are living longer with better quality of life, and they need to be treated for anemia if it's a coexisting problem. And prevention, I've talked to you in detail about how you can prevent anemia from occurring by taking care of everything that is to be done right from birth till prophylaxis till the age of 19 for boys and continued prophylaxis for women till they attain menopause. So coming to cure, basically, most fulfilling part regarding all the causes of anemia till date, other than the nutritional anemia where the prevalence continues to be high, I think providing transplant to certain conditions has been very fulfilling in the last decade. In terms of various other, I'll go through the presented with pallor was found to have hypoplastic marrow. He was macrocytic anemia, and as an approach to macrocytic anemia, what we did, she had a low TLC and a low platelet count as well. We looked at the marrow. Marrow was showing she had a borderline B12, but because she didn't have hypersegmented neutrophils, she did not have a typical picture of on peripheral smear. We suspected that she could be aplastic anemia because she had low TLC and low platelet count, also significantly low platelet count. Though in B12 deficiency, you can get platelet counts which are low. Looking at her clinically, we did her marrow, and her marrow happened to be hypoplastic. The biopsy was showing hypoplastic anemia. She underwent transplant after undergoing various other studies like chromosomal breakage and whole exome to understand whether she was acquired or inherited cause of aplastic anemia. So these are certain fulfilling journeys of patients with anemia where they have benefited with transplant, like the transfusion-dependent thalassemia, sickle cell anemia when it is indicated with significant crisis, Fanconi anemia, sideroblastic anemias, congenital dyserythropoietic anemias, and DBAs. So we have transplanted all such conditions, and the results are quite fulfilling, challenging but fulfilling. So that is one more hope of how we can deal with anemia in children. But the challenge still remains, and I would recommend everyone goes through this article because the biggest challenge in our country currently is nutritional anemia. And with this, I would request Purvi to talk more about iron supplement. I'll just stop sharing.
Thank you so much, Ratna ma'am, for such a lucid and excellent practical insight into nutritional anemia, delivered with such a remarkable clarity and relevance. It's really a mammoth task to touch upon everything, starting from the cord clamping at birth to adolescent girls to pregnancy, including each and everything about the refractory anemias as well as when to go ahead with the pediatric hematologist. Actually, being in a public hospital, I have been witnessing the tireless efforts of the community health workers at the grassroots levels, and they keeping on going on deworming as well as giving the iron tablets in the schools and taking so many efforts. So, as you rightly said, under NHM as well as under Anemia Mukta Bharat, there are so many prophylactic doses available, which we as the general pediatricians, by aligning our everyday general pediatric practice in the cases where the patients reach out to us, like breath holding spells or so many other things. It is our duty and responsibility to pick these children properly and make them reach their targeted hemoglobin. Then only this achieving the vision of Anemia Mukta Bharat is going to be a shared responsibility of the community workers as well as the clinicians. Another important aspect which you have stressed is CBC is, as rightly said, is a mirror of the marrow happening in the body. So we have to, as a general pediatrician, start interpreting all the indices very thoroughly, properly. As well as another important point I loved was when we as a pediatricians are catering to the community, it is our important role that while going to the school or at the point of care, hemoglobin testing, we are going ahead with so many advances. CIPLA also had last time got this as a presidential action plan in the last time's hemoglobin detection. So these new investigating tools should make this problem very easy to solve in the coming future. So sincere appreciation for such a meaningful and practice-oriented talk. Now we have so many iron supplements available, which to choose, which not to choose, how long to give, whether to use FCM very safely and make the child uh, fit for anesthesia and get it lost permanently. So we have none other than Dr. Purvi to discuss upon all these aspects. I have a request to all the delegates. Please kindly put your questions in the chat box so that we can finish the session in time. Dr. Purvi Kadakia Kutti is a senior consultant in pediatric hemat and onco and BMT physician at Sion Hospital, New Era Hospital, Vashi, and we all know at Apollo Hospital, Navi Mumbai. She is a faculty and accredited teacher for FNB Pediatric Hemat-Onc at LTMG Sion Hospital. She has more than 15 years of experience in the field of pediatric hemat immuno-onco with expertise in pediatric BMT for both benign as well as malignant hematological conditions. Dr. Purvi has completed her undergrad training from Nair and she had always been a very important person in getting the hemat department established in Nair Hospital. She has lot many stuffs to her name. Before, rather than going on to all the details, I would ask Dr. Purvi to come, and this is basically a very small topic given to you where you have been so much instrumental in pediatric blood cancers, awareness of immunity. But we thought from Navi Mumbai IIP that rather than discussing into those diseases or illnesses which a general pediatrician might not be coming into, so we have chosen this topic for you. And as passion, you would definitely give a justice to that topic. Over to you.
Thank you, Dr. Madhvi, for such a kind introduction. And yes, I'd like to share my screen. Just 1 second. So on the offset, I would also, can everyone see my screen?
Yes, ma'am.
Yeah. So good evening, everyone. And thank you, team IIP Navi Mumbai, for inviting me and giving me the opportunity for this talk. Already the power presentation has been preceded by Dr. Ratna, where she has covered most of, why anemia is important and why we must address it. What I'd like to do today is cover iron supplementation tips for everyday practice. So iron deficiency, as we all know, remains the most common nutritional deficiency worldwide. And despite knowing it all, we still struggle with dosing confusion, which formula to use, whether should I give drops or injectable or tablets. We still deal with poor compliance in everyday practice and treatment failures. So what I'd like to focus today is just answer 10 practical questions which every pediatrician faces, not based on your textbook theory, but on practical everyday practice tips which we can apply backed by science. So moving on to my first question, I already saw it in the chat box. At what age should iron supplements be started in a full-term normal birth weight baby who is exclusively breastfed? So the time is mentioned by various guidelines, including the IIP guidelines, is at 4 to 6 months at a dose of 1 milligram per kg per day of elemental iron, until appropriate iron-containing complementary feeds can be introduced in the diet. And ideally, the guidelines say that you should continue till 12 months. Now, why not earlier? Because full-term babies are born with adequate iron stores, which usually last them for about 4 months. And then as the stores decline, breast milk is not adequate enough to meet in the demands. And the infancy is a rapidly growing period, so the iron requirement is more. Why this is specifically more important in the Indian context? Because maternal anemia is also very common. So there may be inadequate or inappropriate stores. delayed cord clamping, which was mentioned as one of the preventive strategies which we must apply, is not universal pan-India, and complementary feeding practices may be suboptimal. So what age should iron supplements now? Moving on to the second counterpart, that is the preterm babies. When should we start iron supplements in preterm babies? It's earlier than your term babies, 2 to 4 weeks of age. Why earlier? Because the main transfer of the iron stores from the mother to the fetus occurs in the third trimester. So they have missed most of building up of the stores of iron from the mother. So we need to start the preterm babies at 2 to 4 weeks of age. The dose is higher, elemental iron of 2 milligram up to 4 milligram per kg per day, maximum of 15 milligram. This, mind you, the dose is the elemental iron, and it's required throughout the first year, even if the baby is on supplements or fortified feed. Why early in infancy? Again, because they miss the transfer of stores, which is crucial and happens in the third trimester. They have a rapid postnatal growth, and hence iron requirement is higher in the preterm babies. So before we treat anemia, as Dr. Ratna already mentioned, we should know the definition of anemia. It is based on the age cutoff, and it is this is the WHO definition of anemia. Children between 6 months to 5 years when the hemoglobin is less than 11 grams per DL. For children between 5 to 11 years when it is between less than 11.5, and for adolescent age group when the hemoglobin is less than 12. So this is defined as anemia in children. Now, why does iron deficiency in brackets anemia matter more in children? Iron deficiency per se, iron is not only needed for erythropoiesis, that is to maintain your hemoglobin level, or the last part is it causes anemia, but iron is important for oxygen transport, your cellular oxidation, various growth processes. And as Dr. Ratna already said, in conditions which have a correlation with iron deficiency is pica, febrile seizures, stroke. Iron deficiency itself impacts the learning, the attention span, growth, physical strength. It decreases the immunity of the child, and hence this overall leads to decreased productivity and an increased economic burden. So we should remember that even before the setting of anemia, iron deficiency can impact the child in various ways. Now, what is the difference between iron deficiency and iron deficiency anemia? It's as simple as we know. Iron deficiency anemia is when hemoglobin is low along with a low ferritin, and iron deficiency is only when the hemoglobin is still not affected, only your ferritin is low. Why is it important? Because you have already missed the boat if the child presents with iron deficiency anemia. Low IQ scores, neurocognitive development, all that have already started to get hampered even before the setting of anemia. So moving on, that why is it so important? In our country, we know, as Dr. Ratna mentioned, that there is this National Family Health Survey, which is alarmingly has raised concerns because the prevalence is going on increasing. So what was done recently shows an alarming prevalence of 67% of iron deficiency anemia or anemia in children under 5. And this has increased from the previous survey. State-wise also, we have covered that Maharashtra is almost similar to pan-India prevalence. And in fact, in some states or districts in Maharashtra, it's as high as 85%. So why is nutritional anemia more prevalent in India? So as we can see from the slide, you can see 3 common staple foods, that is milk, rice, and roti. These are the core of a typical Indian diet, especially in children. Now, what is so bad with this diet? It is predominantly cereal based and excessive consumption of milk. All this has high calcium, high phytates, which impact on the iron absorption and in turn lead to iron deficiency anemia. So what are the iron-rich foods or the iron sources? Many times when the parents come, we should be able to tell them what are iron-rich foods available and how to appropriately give them a good complementary diet. So there are 2 sources of iron. We have the vegetarian or the non-heme iron, which is present in green leafy vegetables, your soya beans, your legumes, pulses, jaggery, peanuts. And this, in fact, the non-heme iron has a poor bioavailability compared to the heme iron, which is present in animal sources, that is poultry, fish, and eggs. So the animal sources or the heme source of iron has a better bioavailability, and it is not hampered by your dietary factors or foods which interfere with iron absorption. So moving on to that, what are foods which affect iron absorption and why is it important? Because even when we supplement the child with iron, we should know that there are three broad factors which impact iron absorption. One is the source of iron, that is whether it's a heme iron or a non-heme iron. Second is the gastric acidity. So should usually avoid iron on patients who are on long-term PPIs, it will impact with the iron absorption. So acidity or the gastric acidity is important factor for iron absorption. Foods which reduce iron is your calcium-rich foods, that is milk, butter, cheese, even calcium supplements, tannins and polyphenols, that is tea, coffee, all herbal teas, cocoa, etc., and phytates. Again, that is your wheat, bread, and your bran. All these will impact the iron absorption, so they should be avoided immediately or after iron supplements. Foods which increase the iron absorption is vitamin C, that is, so prefer to give the supplements with orange juice, acidic foods like tomatoes, fermented food, and of course the heme iron sources or the animal sources of iron. Now, moving on to the most asked question, I think everyone is going to ask me, which iron preparation do you prefer? What do you give in your office practice? First and the foremost important principle is to remember that oral iron supplements are the least expensive, most easily available, and should be preferred compared to parenteral iron. Now, the first principle of oral iron preparations are your bivalent iron salts. That means your ferrous salts are 4 to 10 times better absorbed than your ferric salts. So always choose your ferrous over your ferric salts. Now, the time tested and the most widely available ferrous sulfate, in fact, it is available through all the national programs. They are inexpensive, available freely at BMC hospitals, is your ferrous sulfate, which is available both in the syrup form as well as the tablet form. A word of caution is sometimes the shelf life of the syrup is not as good, but still it is the best and the standard form which should be preferred. What are acceptable alternatives to ferrous sulfate? Ferrous gluconate, fumarate, succinate, and lactate. Okay, a word of caution again about the so-called marketed colloidal iron or iron polymaltose complex. They say that it has a better, less GI tolerance. I mean, better efficacy, but however, it has poor absorption. So the colloidal ions that is present in your tonoferon syrup or tonoferon drops are not to be preferred. Newer iron preparations like your ascorbate or biglycinate, these have slightly better GI tolerance and higher bioavailability. Again, the cost of 100 milligram of elemental iron, which was shown in a recent paper, can be anywhere between 1 rupee to 200 rupees. So it does not matter whether you're using an inexpensive one. You should know how to dose correct, how long you need to give it, and which preparation to give, and with what foods you should give it. Okay, so the dose of the elemental iron, now this is for the treatment of iron deficiency in children, is 3 milligrams per kg. In fact, even the IAP studies, some of the studies say 2 to 3 milligram per kg of elemental iron. How do we give it? Ideally, it has to be given fasting. If not tolerated, fasting can be given in between the meals. Once daily is good enough as 3 times a day. So earlier, I think when I was doing my MD, Nelson mentioned 6 mg per kg of elemental iron given in 2 or 3 divided doses, but this no longer holds true. We can give as low as 2 to 3 milligram per kg, and just a once daily dose is adequate. In fact, even to increase the absorption or the tolerance in adolescents, it is even advocated to give it alternate day. That's good enough. How much duration we need to give it? Once your hemoglobin is normal, that means any mild to moderate anemia will take 4 weeks for your hemoglobin to come up to normal. That after that, you need to give it for 2 additional months. That means a total of 3 months for treatment of iron deficiency anemia. So your dose, frequency, duration, and your preparation. If this is This is actually the main crux in giving oral iron supplements rather than looking for fancy brands or newer iron preparations. Okay, so this slide, I just don't want to advocate or promote any of the iron preparations. I just want to highlight that there is a vast number of iron syrups, tablets, etc. available in the market. And even when we see a patient at office practice, we ask the patient, or one must ask the patient to bring the bottle or the tablet so that you know what salt you are giving, how much elemental iron does it contain, and whether some of the, so for example, tonoferon drops which are shown here or the tonoferon syrup has colloidal iron, which is not recommended in the treatment of IDA because it has poor efficacy and bioavailability. Again, I'm showing you Vitcofol syrup. So there is Vitcofol syrup available and Vitcofol drops available. Vitcofol drops do not contain iron. So if they are given as prophylaxis for iron, but it only has B12 and folate, whereas Vitcofol syrup has iron, B12 and folate. Now again, Dex Orange, which is commonly used by pediatricians, has the ferric compound, which has 4 to 5 times less bioavailability. So make sure you may not remember all the brands, all the salts. What you need to know is always ask the patient to bring the bottle in clinic or whatever their tablets are, so you can go through how much elemental iron is present and which salt is present in each. So another common question which is asked by parents or even by routine by pediatricians, they stop the iron. So should I withhold iron supplements or iron syrups when the child has a minor ailment like a URI, loose stools, or is under the weather? So the answer to that is, please do not stop iron for intercurrent minor ailments. There is no correlation of iron exaggerating any infection. Unless the child cannot take orally or is admitted with severe sepsis, iron routinely should not be withheld in intercurrent minor ailments. Now, what should I inform? This is another common question which is asked by parents or by pediatricians, that how much GI adverse events of iron is going to happen to my child. Avoid highlighting GI side effects. In fact, what most of the placebo controlled trials have demonstrated, that the lower dose of iron, that is 3 milligram per kg, causes less GI adverse events. What the parents need to know, that there is a potential for nausea, dark colored stools, constipation. So that's why it's important to remember that these tablets are taken in between meals, if not fasting, taken in a once daily doses. The tablets should not be broken or chewed. They can be swallowed. The syrups should be kept to maintain the shelf life in a dark, cool space. And as Dr. Ratna mentioned, periodic deworming with albendazole is recommended. Now, this is coming on to the most important question. When a normal child comes to you in routine practice, say they have come for their vaccination certificate, or they've come for vaccination, or they've come for a well baby checkup, and you see this child with minor complaints or maybe a cough cold in clinical practice, will you recommend iron supplements to such a child? Does not have anemia, is not looking pale. The answer lies in the Anemia Mukt Bharat program, or what was already talked about previously, the intensified NIPI, that is the National Iron Plus Initiative, which is advocated by Poshan Abhiyan. Yes, all children should be on iron at all times. Okay, so even if the child is normal and does not require treatment doses, he should be on some sort of iron throughout his life. So 6 months to 5 months, you give 20 milligram of elemental iron bi-weekly. That is sufficient. Children older than that, so above 5 years, require 45 milligram of elemental iron weekly, and adolescents require 160 to 100 milligram of elemental iron weekly. So if everyone remembers by the end of this talk that every child should be on iron on all that at all times, I think that will be sufficient for iron supplements. Remember that it's not important to choose the brand, but taking iron regularly is important. If parents are concerned about staining of mouth or if nausea or something, it can be, you can tell them to rinse the child's mouth to avoid teeth stains. In small babies, you can use a syringe. Milk and dairy products and calcium supplements should be avoided 1 hour before and 2 hours after the iron dose. So this is important. How will you monitor the response to iron? Most importantly, after you start iron, within the first 12 to 24 hours, there is a dramatic improvement in the appetite and generalized feeling of well-being. In the first 72 hours, there is a rapid retic response. So on the smear, you will see polychromasia, a good retic peak, and then the hemoglobin gradually rises. It may take 2 weeks. You need to reassess. In a severe anemia, in a mild to or moderate anemia, you will see a rise in hemoglobin by the end of 4 weeks. And finally, the repletion of stores takes place after 3 months. So you need to continue iron supplements when you're treating for iron deficiency anemia for totally 3 months. So what is apparent failure of iron in deficiency anemia? One is poor compliance. Always check the preparation, the dose, and the formula the child is taking. Excessive milk intake. So what is excessive milk intake? More than 500 ml of milk will impact on your feeding, on your complementary feeding, also on your iron absorption. So that can be an apparent cause of failure for iron deficiency anemia. When the child has any inflammatory bowel disease or celiac disease, which is quite common in North India, an alternative diagnosis. So always rule out a thal trait. If you've not screened yet, child is not improving, then rule out thalassemia trait. Still, if the ferritin is low, the child is not responding on oral iron supplements, which are given in adequate dose and adequate duration, then look for hidden sites of occult blood loss. So is the child having a GI blood loss or blood loss in the lungs? And last but not the least, IRIDA, that is iron refractory iron deficiency anemia. So this is one of the causes where you need to use parenteral iron. But do we advocate to use parenteral iron in everyday practice? No, it has a very limited role. Response is not rapid as one would imagine with parenteral iron. It is indicated when there is a gut absorption and there's a problem with the absorption. So when there is an inflammatory bowel disease, celiac, gut resection, as we have in Burkitt's lymphoma, or any gastrectomy which is done, or an iron refractory iron deficiency anemia where there is a problem mutation with the TREMPS6 receptor, or most abused probably causes poor tolerability to oral iron. So I'd like to end my talk with this, that every child should be on iron all the time. And I hope it's open for discussion so we can take questions.
Thank you so much, Dr. Purvi, for such a wonderful talk, which is definitely of a practical use to all the general pediatricians. And rather than giving the high funda knowledge, it made us so much, it gave us so much clarity to start iron at a term infant, for when to start at a preterm baby, which salts are to be used. So the age-old knowledge learned in pediatric hemat of ferrous versus ferric versus colloidal iron still holds true, and that we need to keep on re-emphasizing while giving supplements to the parents. As you rightly said, Anemia Mukta Bharat and NIPI initiatives are very important, and we as the general pediatricians have a crucial role to implement it in our day-to-day practice rather than treating only cough, cold, fever. And the way we are scientifically approaching the rational use of antibiotics, we also do have a social and a moral responsibility to build our next generation on a proper way on an iron frontier basis. Now, I would like to ask, take the questions from the chat box. The question first was, whether do we have to check the response to the iron after 2 to 4 weeks of starting the treatment? The question can be taken by both Dr. Ratna as well as Dr. Purvi, anyone.
Purvi, you can take the question because you were talking about it.
I think severe anemia, you should reassess the child that you're not missing anything else. So at 2 weeks, we should reassess and see if there is a documented improvement and hemoglobin rise. Otherwise, it's if after 4 weeks, if the child is doing well in a mild to a moderate anemia, you need not always document a rise in hemoglobin. But yes, for severe cases where the hemoglobin is less than 7, I would call the child back and reassess clinically as well as document the hemoglobin.
Okay. Another question has already been answered, but still, Dr. Rushikesh wants to know, as per NIPI guideline, only twice a week iron folic acid supplementation is advocated from 6 months onwards till 5 years of age. So for the full-term babies, how do we use iron supplements on a daily basis or only twice a week basis?
Twice a week is good.
Twice a week, yeah.
Yeah. Any role on microsomal iron? Any word about microsomal iron supplementation? Liposomal iron supplementation.
Liposomal
Which
iron liposomal iron did come into the market, and it was being advocated, and there were people who were recommending it to the pharmacology, the pharma companies. But what we realized, the cost was more. It was basically being advocated in those who were not tolerating. But if you correctly guide them how to take at with the intervals between food or after dinner, the GI tolerance is better. And with the doses now recommended of just 2 milligram per kg, the tolerance to routine iron, with the salts that Dr. Purvi just talked about, we are not seeing so much of compliance issue. So there was a wave where this liposomal was available, but we didn't find it to be too useful, and the cost, it's way too high, the cost.
okay.
So on one-on-one
So
basis, if you are getting really a fussy child or a fussy family, then, and the dose is less, the dose is around 1 milligram per kg.
okay.
Not used
Another
it.
question, Another question Dr. Sham wants to know is, how does gastric pH affect iron absorption?
So we've had patients where we have seen that the absorption is poor because of intake of things which change the gastric pH, like and all. So that fires the gastric mucosa, and therefore the conversion that we expect to happen with the salts that we are, giving, the absorption will not be good. So there is no proven, but yeah, we do advocate, and we had patients who were addicted to such things. So you have to tell them, to avoid all this and then move ahead.
Yes, basically the ferrous is
Drinking,
absorbed
just
better in a acidic pH. That's why it is higher, better absorption of ions.
and just to add on a word, we have as an Indian a tradition of having either tea or coffee immediately after the lunch to keep us alive. So even that is known to decrease iron
Hamper,
absorption,
yes.
hamper
So
iron absorption. So that
I would say they should all move to vitamin C intake rather than
correct,
tea,
correct. So
coffee. So a
adding,
little bit of
yes,
lime juice after meals would be a better idea. And
very
I think
true.
the Indian culture of adding lime juice to your food is a good idea. What we talked about acidic pHs, I'm talking of the extremes about the Coke. So that is what we need to avoid.
Correct. Another question is, what is the ideal time for delayed cord clamping for a stable preterm and a full-term baby, even though it doesn't come into the prejudice of a pallor as such, but experts.
The guidelines have recommended 3 minutes, but I don't know whether it's practically doable.
Actually, as per the revised guidelines, it is mentioned that 30 to 60 seconds and not extending beyond 60 as per the neonatal recommendations is a delayed cord clamping. The situation depends. This is standard for the term babies. Apart from those high risk babies like
Low birth weight and
yes,
preterms.
from the different age groups, 30 to 30, 32 is different, less than 20 are one-to-one condition which is to be uh, discussed along with the depending upon the condition of the baby and the mother. Ferrous sulfate absorption is 20%, whereas ferrous ascorbate is 40%. So which salts are good? And if we administer 3 milligram per kg per day of ferrous sulfate, so 0.6 milligram per kg will be absorbed, whereas the same dose of ascorbate will give higher. So how do we decide which salts and what is the dose?
No, so I think we can, the take home message should be ferrous sulfate is as good as ferrous ascorbate if you take it regularly and you're complying with all the precautions, like not taking it with calcium supplements, and you're making sure that you're taking that much, 2 to 3 milligram per kg, 2 to 3 milligram per kg per day is good enough. But you take any brand, which is the right brand, it doesn't matter if you take ascorbate versus sulfate, both are fine. I mean, ascorbate, the bioavailability is better. So, but you can use ferrous sulfate also. I don't think there is some of the fancy. I think one question was asked about Raricap, which has calcium ammonium citrate. It is better bioavailable, better efficacy, but it should be that you take any iron supplement, the ferrous salts, sulfate, gluconate, lactate, but they should be taken at an appropriate dose and duration.
Another question from the audience is how to overcome constipation in a baby who gets it the moment iron is started, and how to adhere to the compliance, and how to convince the parents that there is no option but to take iron.
I think most of
So,
the most of the trials have shown that the lower dose, that is 2 to 3 milligram of iron, either you make it first, you space out the dose. So either you give it alternate day, or even if they take it twice a week, continue that dose. Also check on the milk intake, because sometimes the milk can increase the constipation and it may not be the iron supplement which is causing the constipation. Anything else? Ratna,
Another major side effect is your staining of the teeth.
Yeah.
So whether it is really reversible and how do we prevent it?
Yeah, so for prevention, I already mentioned that you ask the parent to rinse the mouth after they take in the iron supplement. Sometimes in children who don't do that, then maybe use a syringe and give the iron syrups. And it is reversible.
some older children, opt to take it with a straw after putting it in water as well. Because sometimes girls specifically, they don't want, matters how they look, even for the boys. So I've seen them opting to take it with a straw, and generally then the teeth is spared. They just gulp it in.
The previously available iron polymaltose complex. So where do they stand as of now?
Not recommended.
We've not been recommending it.
Not recommended.
So the basic take-home message is always ferrous salts and whichever best possible combination is available. So that is the take-home message about the supplements.
And take it
Any
regularly.
other question? Take it regularly. The adherence is very important.
The cheaper ones are ferrous sulfate, ferrous gluconate, and ferrous ascorbate. So go in that order and choose. And less the cost, better the compliance for the masses at least.
Correct. And whichever fancy products are coming into the market, we need not break our heads. The take-home message is very clear. And as Dr. Ratna ma'am has already talked about the article in Indian Pediatrics is very crisp, giving all the details. So it's a request to all the general pediatricians, rather than getting thoroughly confused which references to follow, this article is very good. Another question is, in beta thalassemia minor patient, when we know the baseline hemoglobin is around 9.5 to 10, how do we decide about the targeted hemoglobin and when to start iron supplements?
So we have thalassemia, heterozygous trait or minor who are iron deficient in our country also. So the rule is for the masses, they also need to take iron. Okay, a trait can maintain a hemoglobin which is going to be anywhere between 9 to 10.5. You may have traits who are 8 and they will touch 9.5, 10 after taking iron. You can document coexisting iron deficiency in them, and they do have a rise in hemoglobin, which we have documented. They also need to be put on iron prophylaxis program, because we are not screening for thalassemia minor to decide whether iron prophylaxis program needs to be implemented. So this question comes up in a lot of meetings, and a lot of people have this question. Yes, they need to get the iron folate prophylaxis.
As both the stalwarts are there, can we ask a little bit about B12 also?
So I didn't include B12 in my talk because that would have been
Yes,
a lot
but there are comments in
maybe
the
we should
chat
have
box
another
about.
session. We should have another session on B12.
Sure. Uh, Somebody has written whether heme or non-heme, which is better. That has already been discussed. Non-heme being the vegetarian sources and him being the non-vegetarian sources. So that has already been asked. Coming to the end of the session, it is already 10:20, and such a crisp discussion with all the practical aspects and all the doubts being cleared so lucidly by both the eminent speakers. I'm very grateful, and the audience has also given so many good responses about day-to-day difficulties which we encounter. Before concluding the session, I would like Dr. Jitendra, who is a joint convener for the Presidential Action Plan, to give his opinion about this today's session. Over to Dr. Jitendra.
I think both of you are my favorite speakers, and very crisp discussion on iron and anemia overall. So thank you for accepting our invite to come for a discussion, and hope we will take soon B12 session also. Thank you.
Thank you, Dr. Jitendra. I'm sure both the speakers are already engaged for the next session. And the team IIP, thank you very much on behalf of all the pediatricians to take this topic, the PALAR protocol, a systemic approach to the childhood anemia in the office practice. Now I request Dr. Narjon, our another EB member, to express a vote of thanks or gratitude to share this beautiful evening, even though it was so much occupying for all the speakers, both the speakers. Over to Dr. Narjon.
Thank you so much, ma'am, giving me the opportunity to present out of thanks. I would like to thank all my respected seniors, esteemed speakers, dear colleagues and friends. On behalf of Navi Mumbai Association of Pediatrics, it's my privilege and honor to propose the vote of thanks for that so much enriching webinar on the occasion of World Anemia Awareness Day. First and foremost, I express my heartfelt gratitude to our extremely distinguished speakers. We are already deeply thankful to Dr. Ratna ma'am and her insightful talk on the spot the palace and office strategy for the childhood anemia. And it was a very practical and experience-based approach to provide us a valuable guidance and take-home messages, and that will surely enhance our day-to-day pediatric practice, ma'am. And secondly, our sincere thanks to Dr. Purvi ma'am for her excellent session on iron supplementation and practical tips and tricks for everyday practice, and your clarity on the rational use of iron and its supplementation, and what are the common iron preparations are available and how to prescribe them. It was a really excellent and extremely relevant, and I appreciate and thank you so much, ma'am, for your so wonderful talk. And a special word for dear Madhvi ma'am. So she was our esteemed moderator in this session, and for seamlessly conducting the session and maintaining the good flow. And there was a great discussion. And we also extend our gratitude to President ma'am and Jitendra Gavani sir and executive committee members of the IIP Navi Mumbai for their consistent guidance and support to organize such kind of programs. And lastly, I would like to thank all the technical team who was behind all this webinar, and there was a smooth and hassle-free presentation. And last but not the least, I am just having big thank you for you all and participants who have joined us today and making this webinar very successful. Thank you so much once again, and good night.
Thank you, everyone. Thank you.
Thank you, ma'am. Thank you.
Thank you, ma'am.
Thank you.
Thank you
ma'am.
very
Thank
much.
you. Thank you.